In this presentation, we're going to discuss several of the atrial rhythms and some of the atrial issues. The issues that we're going to cover today, or the different rhythms we're going to cover today, are the premature atrial complex. As you notice, it says complex. In the past, they used to say contraction. But realistically, we don't always know that it's a contraction just by looking at the heart monitor. So nowadays, it's kind of a common term to call it a complex. This is kind of an older, antiquated term, as it were. We're also going to discuss what is atrial tachycardia, and there's another term for it. There's also something called ectopic atrial tachycardia. And this is really what atrial tachycardia is. It's an ectopic area, and we'll discuss that as we go into the presentation. The next thing we're going to talk about is a wandering atrial pacer. We're going to talk about a multifocal atrial tachycardia, and these two are very similar, and you'll find that out in the video. We're going to talk about atrial flutter and where that comes from and how you identify that, and of course atrial fibrillation. The first thing I want to discuss are the atrial rhythms themselves. When we talk about atrial rhythms, any rhythm that originates outside of the SA node, so it's outside of the SA node, it is considered atrial. If it originates inside of the SA node, it is considered sinus, and that is not this presentation. So these are going to be considered atrial rhythms. So any rhythm that originates in the atrial tissues, or it could originate somewhere in the internodal pathways. Either way, it is outside the SA node. The problem that we end up with atrial rhythms a lot of times is that the different depolarization areas, the different areas where they depolarize, could actually affect ventricular filling time, and this is especially true if it's excessively fast. Another problem that we could have is that we could lose something called the atrial kick. The atrial kick is about 20 to 30% of filling of the ventricle that occurs with the atrial contraction itself. One major rhythm that we have a problem with is AFib. In atrial fibrillation, you lose the atrial contraction, but people can still maintain a good blood pressure even though they're in atrial fib without atrial contraction, because 70 to 80% of ventricular filling occurs without the atrial contraction. It occurs passively. Over time, though, losing that atrial kick will have a problem physiologically on the body and decrease cardiac output or decrease the effectiveness of the heart working to perfuse the entire body. So there are some causes that occur in atrial rhythms. There's all of the different atrial rhythms. There's a couple different things that would cause these atrial rhythms, and we're going to go over each one of these. Increased automaticity is one of them, a triggered activity, and then a reentry phenomenon, and we're going to go over each one of those. In increased automaticity, what happens is the atrial cells tend to depolarize before the SA node has a chance. So what happens is if you have the SA node up here, and then you have your internodal pathways, and then you have your AV node, and here's your up here your atria, there's an area over here that might have the desire, that might have the ability to be able to depolarize before the SA node. Now the problem with this is that if this little area right here depolarizes before the SA node, there's going to be a wave of depolarization sent out, and what can happen is once it hits this SA node, it can re-depolarize the SA node before it's ready. So that's called increased automaticity. Some of the causes of increased automaticity: myocardial ischemia, if there's any kind of ischemia going on up there, any kind of hypoxia due to maybe not an ischemic issue but just lack of oxygen itself to the tissue, or any kind of atrial stretching, especially in patients who have congestive heart failure, and this is a chronic atrial stretching. This isn't an atrial stretching like somebody had to run up the stairs because they were late for a meeting and you have an increased blood return back to the heart, so now you have an increase in the atrial stretching just to accommodate for the increased blood return to the heart. That usually doesn't cause automaticity unless you have one of these other two problems. This atrial stretching from congestive heart failure is a chronic problem that occurs. Also, any kind of mitral valve disease, increase in pulmonary artery pressure with the disease process or pulmonary embolism or anything like that. A triggered activity is when you have injured myocardial cells that have the potential to depolarize or only partially repolarize. What happens is the partial repolarization increases the chance for an ectopic focus. Now, these are injured cells or damaged cells of some kind, and they're the ones that actually cause the problem here. This is different than an increased automaticity. It is not the same thing. The triggered activity usually occurs from injured cells due to other problems and a digitoxicity. Digitalis is a fantastic drug whenever it's used for certain disease processes and certain heart problems, but boy, it can really wreak havoc on the heart as well with long-term usage. So that's a triggered activity. The next one is called the re-entry phenomenon. What happens in a re-entry phenomenon is that an impulse is delayed along a slow conduction pathway, which means that it actually will remain active. The impulse remains active, and then it will circle back around. Sometimes this is referred to as a circus re-entry. Because the circus reentry, because it actually will go through a slow area, it'll go through an area, and then it'll circle back around. Then it'll go back through a slow area, and it'll circle back around. I'm going to talk a lot more about this here in a little bit, but reentry phenomenon is what causes a lot of ectopic atrial tachycardias or ventricular tachycardias or some kind of tachycardias. Most of the time, or a lot of the times, it is a reentry phenomenon. Some causes: coronary artery disease, cardiomyopathies, and of course myocardial infarctions. So the first thing we're going to discuss here is the premature atrial complex, also known as the PAC. The premature atrial complex is just an early ectopic beat that originates outside of the SA node. It could be one site or multiple sites, and the way that you would tell the difference is that you would look at the P waves. It is usually a result of increased automaticity, remember that one, or the reentry problems. And we're going to talk about reentry here in a little bit. Just to describe where a PAC actually comes from and how to identify the PAC, this is really important here. As you can see here, let's look at the left picture over here. If you look at the left picture here, this star right here, that indicates that that's the PAC. That's the ectopic focus that originates the PAC itself. What happens here is when this star depolarizes, or when this ectopic site depolarizes, it will actually send out a wave of depolarization just as if it were the SA node, and it will cover the entire atrial area. Now, it could re-depolarize the SA node, or it may not re-depolarize the SA node. If the SA node depolarizes shortly after this ectopic area depolarizes, the SA node will start sending out its wave of depolarization, and when these two hit, it will actually cancel each other out. So there's a couple different things going on there with the PAC. How you identify it on the rhythm strip is what you do is you look at the right picture. Now, if we look at the right picture over here, as you can see, you have a standard P-to-P interval that's identified right here, and then you have another standard P-to-P interval that's supposed to occur right here, but as you can see, there is a premature complex there. That's where you get the premature. The reason it's called premature is because the P wave comes early in the cardiac cycle. Another way that you can identify that this is a PAC is if you look at this P wave right here and look at that P wave right there, you can see that this P wave has a different morphology. All of these other P waves have almost the exact same morphology. But you also have to look at the QRS complexes. Outside of the P wave here, look at all of these QRS and T waves right here. all of these QRS and T waves, even in the PAC, they all look the exact same. The only thing that changed here is the P wave. So what you end up with is a problem that occurred above the ventricles, because if you remember, the QRS and the T wave signifies ventricular depolarization. And if all of the if all of the QRS and T waves are all the same, then you know this is not a ventricular problem, it is an atrial problem. This is how we can identify a a PAC. So let's look at another quick picture here. This would be an example. This is not a PAC. This would be an example of a normal sinus beat that originates up there in the SA node and depolarizes that way. You have a normal P wave right here. If we go to the next picture, you see that probably the ectopic focus was down here somewhere, traveling up in that direction right there, which in this case would give us an inverted P wave. The P waves in PACs do not have to be inverted. This is just an example. Other P waves could be positively deflected, but these will be a different morphology than the normal QRS, PQRS-Ts that you would see. They could be biphasic this way. They could be biphasic, they could be biphasic the other way, like this. They could be any different morphology, and they have to occur early in the cardiac cycle. What occurs after the PAC is usually going to be some kind of a pause. Because the PAC occurred early in the cardiac cycle, so if we have a sinus beat, a sinus beat, a sinus beat, and then we have a PAC right here, and then we have a sinus beat over here, you're always going to have this pause right here. Somewhere, somehow, there's going to be a pause. Now, what we should figure out is if this pause is considered compensatory or non-compensatory. And the question you have to ask is, was the SA node reset due to the PAC? Was the SA node reset due to the PAC? The non-compensatory pause, we're going to talk about this one first. In a non-compensatory pause, what happens is the PAC reset the SA node. Now what that means is, if you have your SA node, I'm going to put your SA node up here, and I'm going to put your AV node down here, and we're going to have our internodal pathways. Now in a non-compensatory pause, let's say you had a PAC that occurred right here. The wave of depolarization from the PACs will still travel out and depolarize the entire atria, both atria. And what happens is the SA node was depolarized secondary to this PAC, which means the SA node, the interval for the SA node was reset. So what happens is the SA node is no longer firing on its initial interval because this PAC here reset the interval. In a compensatory pause, this means that the PAC did not reset the SA node. So if I have this is a compensatory pause, so if I have my SA node up here and my AV node down here, and here I have my internodal pathways, let's say that this PAC fires off right here. As this wave of depolarization travels through the atrium, maybe this SA node also sent out a wave of depolarization as well because it was trying to depolarize. Now these two signals are going to get here and they're going to cancel each other out, which means this SA node is still going to continue to depolarize at its exact interval that it was initially depolarizing, because this wave of depolarization from this PAC didn't touch this rhythm over here. It didn't touch this interval over here. So let me see if I can give you another example here. Let's say for the non-compensatory pause, the PAC reset the SA node. So we have a sinus rhythm here and a sinus rhythm here, and let's say you have a PAC right here. Now the next sinus rhythm is supposed to occur right here but it can't because the SA node actually was reset by the PAC. So it doesn't occur here, but because this right here was the interval for these SA node depolarizations, this one here was supposed to be the next one, but it wasn't. It occurred here. So what happens is now your next SA node depolarization occurs here. Now what's interesting about this is if you march this out all the way through, what happens is the intervals up here don't match the intervals back here. And I'll explain that in the rhythm here in a little bit. So let's talk about a non-compensatory pause here. Since the P wave does not fall right here on an exact multiple of the P to P interval, then that means it is a non-compensatory pause. So here's your P to P interval. There's a P wave here and there's a P wave here. The PAC occurred right here. So as you can see, the next P wave, according to this illustration here, was supposed to occur right here, but it did not. But let's march it out. This is still, the next P wave should still occur right here if the PAC did not reset the SA node. But as you can see, this PAC right here screwed everything up. So you have your PR interval, your P to P interval is fine, but it doesn't march out from the front side of the strip to the back side of the strip. Your P to P intervals do not march out. Now, if your P wave had landed right here after the PAC, this would be compensatory. But since it does not land right here after the PAC, it is not compensatory. So now let's look at a compensatory pause. And you can do this if on your handout if you have calipers. I just don't have a caliper capability right here, unfortunately. So we have our P to P interval. Here's a P wave. We have a certain spacing. There's a P wave. And here's our PAC right here. Now we're supposed to have a P wave right here. The question is, did this PAC reset the SA node? Or did the SA node not get affected at all by this PAC? And the answer is it wasn't affected at all because your next P to P interval occurred normally right here, which means if you look from the front to the back side of the strip, if you take your calipers and march here, the next march will be here and the next march will be here right where it's supposed to be. This is a compensatory pause, which means it marches out from the front to the back. These are some causes of the cardiac disorders or of the premature atrial complexes, cardiac disorders, drugs, and other stuff. It's all pretty straightforward stuff. Now let's go ahead and start looking at the different patterns of PACs. When we have any kind of premature complexes, and this could be atrial, this could be junctional, this could be anything, but we're talking about atrial complexes. If the atrial premature complex, whether it's atrial, junctional, or ventricular, if the premature complex occurs every other beat, it is considered bigeminal premature whatever complex. So as you can see here, you have a sinus beat, a PAC, sinus beat, PAC, sinus beat, PAC. So every other beat is a premature complex. If every third beat is a premature complex, it's called trigeminal or trigeminy. So we have a sinus beat and a PAC. Then we have a sinus, sinus, PAC. Well, probably there was a sinus beat over here somewhere. Sinus, sinus, PAC. So every third beat, 1, 2, 3, trigeminal. 1, 2, 3, trigeminal. 1, 2, 3, trigeminal. Now this has to be a constant pattern. If you have PACs that occur every 2 beats, 4 beats, 3 beats, 9 beats, 5 beats, you can't call that a bigeminal or trigeminal. Usually bigeminal and trigeminal occur on a regular basis where every third beat throughout the whole strip is the premature complex. In quadrigeminal, quad being 4, of course, you have a 1, 2, 3, and then the fourth beat is your PAC. So you have 3 normal beats and then a PAC. That would be considered quadrigeminal PACs. So let's go ahead and start interpreting some rhythms now. First thing you want to do is you want to look at your atrial rate. This is the first thing you want to do is you always want to follow the step-by-step process until you can look at these and identify them. It takes a lot of practice to do that. You want to follow the step-by-step process. The more you follow the step-by-step process, the faster this will become. Don't try to jump up to the level of just staring at it for a second and automatically interpreting everything. It takes a lot of practice. So let's start with our atrial rate. Our underlying atrial rate is starting here. I like to use a countdown method, so 300, 150, 100, 75. So we have a 75 beats per minute. The ventricular rate looks to be about the exact same as the atrial rate, so we're going to say the ventricular rate is also 75 beats per minute. Is it regular or irregular? Well, if you just glance at it, you can see right here that there's an irregularity. It's a premature beat, and we just need to figure out what it is. So here's our regularity is going to be irregular. Are there P waves, and are they married to the QRSs? Yes, they are, present and married. The PR intervals. It's kind of hard to do this without calipers, but I'll give it a shot. There's one here, there's one here. That looks to be 1, 2, 3. That looks to be about 3 boxes. So we'll say 0.12 second. The QRS complexes look nice and narrow, so we'll say that is 0.10 second. Now there's a problem with this rhythm here, and your problem is the regularity. This right here, we need to figure out why is this rhythm irregular. If this were regular, then we could probably say this is a sinus rhythm with no problem. But now we have a problem. It's irregular. So first thing we need to do is identify the underlying rhythm. The underlying rhythm meets all the criteria for a sinus rhythm. But now we have to figure out why is it irregular. We have to put that into our interpretation. Well, in this case, we look at the irregular beat here, and what do we have? We have a P wave that looks a different morphology than every other P wave that we have down here. So it's a different morphology, and if we march this out, so we have 1, 2, 3 and a half. Did I do that right? No. 1, 2, 3, 4 big boxes. 1, 2, 3, 4 big boxes. This is where the next one is supposed to occur, and it occurred early in the cardiac cycle. So we know it's premature. Is it atrial, junctional, or ventricular? Well, we're covering atrial, so we all know what the answer is. But what you want to do is you want to look at the P wave here. It still occurs in a normal PR interval. And look at the QRS complexes. All of the QRS complexes are the same, even in this anomaly right here. So we know that because the P wave is different and the QRS is normal, then we know that it's an atrial complex. But we're not done yet. Does this have a compensatory or a non-compensatory pause? Well, we can kind of figure that out. If we look down here, you can see it occurs here. So here's 1, 2, 3, 4 boxes, I'm estimating. If you have calipers, you can do this really well. So 1, 2, 3, 4 boxes is supposed to be the next one, and we keep counting. 1, 2, 3, 4 boxes. Okay, well, I started with the QRS complex. It looks to me that this is actually a non-compensatory pause. Supposed to be an A with a U. With a non-compensatory pause. What that means is this PAC right here reset the SA node. The way that I always try to remember this is a non-compensatory pause does not march from front to back, which means the P waves or the QRS complexes, whatever, do not march out from the front side of the strip to the back side of the strip. Since they didn't march out, because as you can see here, this is where it actually landed, and it was supposed to occur here. So it didn't march out from the front to the back through the PAC. That means that it was a non-compensatory pause. The next one we have here, wow, this looks really slow. So we're going to look at this and see the atrial rate, 300, 150, 100, 75, 60, 54. Ooh, wow, that's like less than 40. So we're just going to call it 40 beats per minute. The ventricular rate is 40 beats per minute. The regularity, just by glancing at it, you can tell that that puppy right there makes it irregular. The P waves are present and married. The PR interval, let's see if I can do this, from here to here looks to be right at 0.20 second. The QRS complexes, they look a little weird. See this huge ST segment depression right here? That's just a depression. That doesn't change the width of the QRS complex. That just changed a different interpretation. So it goes from there to there. That looks to be about 1, 2. So we'll say that's a 0.08 second. So the rhythm interpretation, remember, you have to interpret the underlying rhythm first. So what is the underlying rhythm? So all of these other criteria here meet a sinus bradycardia, but we have a problem. Here's your irregularity. So we have to figure out, why is this thing irregular? We have to interpret why this is irregular. So we know that this interval right here is a lot shorter than this interval here. So we know that it's something that's premature. The QRSs look the exact same, so the ventricles weren't affected, but we do have a P wave out here that occurs. It looks to be about a 0.20 interval as well, so it meets all the criteria for a premature atrial complex. And you can abbreviate this as PAC also. So now we have to figure out, does it have a compensatory or a non-compensatory pause? Well, it's kind of tough to tell, but we'll actually see if we can give this a shot here. So here's this. Here's 1, 2, 3, 4, 5, 6, 7, 8 big boxes and about 3 little boxes. So let's see if this does this again. 1, 2, 3, 4, 5, 6, 7, 8 big boxes. And then 3 little boxes puts it right about here. So it doesn't actually look like that the P waves are marching out here. So all the way through. So since the P waves do not march out from front to back, this is a non-compensatory pause. And remember, a non-compensatory pause, when it does not march out from front to back, means that the SA node was reset. Starting off with our atrial rate, it looks to be, we can start right here, 300, 150, 100, 75, 60, 50, another about 40, so we're going to estimate it about, we'll say 45. Ventricular rate 45 beats per minute, and the only reason I do that is because the atrium and the ventricle, there's a P wave before every single QRS complex. The regularity, if you look at it, you can see here that this third beat here makes it irregular because it occurs prematurely. The P waves are all present and married to the QRSs. The PR interval, let's look down here. We have it starts right about here, goes to here. That is 1, 2, 3, 4 little boxes, so 0.16 second. The QRS complexes, this is really hard because you see this sloping right here. This is kind of an early repolarization thing going on with a lot of scooping here. So there's an underlying condition going on right here that you would want to do a 12 lead for, but it looks like that as it starts to scoop right here, it still looks normal, so we'll just go ahead and call it 0.12 second. If you do a 12 lead, it would be able to give you an exact number here for the depolarization. The interpretation, underlying rhythm always goes first. The underlying rhythm is a sinus bradycardia with what? Now we see here that it's irregular, so we have to identify why exactly is that due to irregular. So let's start here. 1, 2, 3, 4, 5, 6, 7 and a half or so. Okay, so we're going to go 1, 2, 3, 4, 5, 6, 7 and a half. So you can see it occurs early in the cardiac cycle, so it's a premature. The P waves are actually different in this one. So you can see you have an atrial complex here, or an atrial beat here, and an atrial beat here, and you can see the P wave is different, but it still occurs within the normal PR interval right here, and the QRS complex is the exact same with the premature beat as every other beat. So in this case, you know for a fact that there is nothing going on in the ventricles, because all of the ventricles are depolarizing the same. So let's go ahead and look at this. We know that it's a premature atrial complex. But now we have to figure out, is it a compensatory or a non-compensatory pause? So if we start right here with this P wave, we know right here on this line, so we have 1, 2, 3, 4, 5, 6, 7, and 3 boxes here. So let's go 1, 2, 3, 4, 5, 6, 7, and 3 boxes here. 1, 2, 3, 4, 5, 6, 7. Oh, look at that. And 3 boxes. So it's almost the exact same. Now, the literature I got this out of actually said that it is a compensatory pause. I might have miscounted here because I'm doing counting rather than actually using calipers. So use your calipers and see if it actually does march out. And if it does, then you can see that it marches out, but it has to march out from front to back through the anomaly right here. So this is a sinus bradycardia with PAC and a compensatory pause. And the only reason I'm doing that, like I said, the literature I got this out of said it was a compensatory pause, not the other one, and I don't have calipers. If I had calipers, I could probably be a little bit more definitive. So if you marched it out and it does not march out and it is a non-compensatory pause, then it'll be considered a non-compensatory pause. I'm going to go through the rest of these pretty quickly, so if you want to pause the video and interpret the rhythm first, and then you can kind of see what the answers are, then you can do that. Otherwise, you can just skip through the rest of these atrial PAC rhythms and stuff. So the first thing we're going to do is we're going to identify the sinus, the rhythm itself, the rate, I'm sorry, the atrial rate. So we have 300, 150, 100, 75, 60, 50. So we'll say 58 beats per minute, 58 beats per minute. Regularity is going to be irregular. The P wave is present and married. The PR interval looks to be about 0.16 second. QRS complex looks nice and narrow. The underlying rhythm is going to be a sinus Brady. And this is your PAC right here. So we know that the third beat is the PAC. That's a different P wave, as you can see from that P wave right there. And the literature I got this out of with the PAC, remember the P wave is different, but the QRS and T waves are normal. They're all the same. The book I got this out of said it was a non-compensatory. Because it's a non-compensatory pause, that means that the P waves did not march out from the front to the back. And a non-compensatory means the SA node was reset. This one looks a little bit faster, so what do we have here? We have atrial rate of 300, 150, 100, so probably a little bit faster than 100. We'll call it 110. The ventricular rate, it's irregular. P waves are present and married. So it would be an I. The PR interval looks normal, 0.16 maybe, actually 0.12 second. The QRSs look a little bit wider than they're supposed to, so I'm saying they're pushing 0.12 second also. The interpretation, remember, underlying rhythm first. The underlying rhythm is a sinus tach, but we do have an irregularity here that we have to identify. So we can see a PAC right here, a PAC right here, and a PAC right here because the P waves are different than every other P wave in there. And what's interesting about this also is that the QRS and T waves are all the same. So that tells me that this is an atrial problem, not a ventricular problem. But let's also look at this and see you have a sinus, 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 PAC, sinus, 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 PAC, sinus, 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 PAC. So that tells me 1, 2, 3, 4, 1, 2, 3, 4. So we have a quadrigeminal PACs with, now this gets difficult because are these compensatory or non-compensatory pauses? Go ahead and take your calipers and march it out and see what it comes out to. The book I got this out of said it was a non-compensatory pause. The atrial rate for 13-6, 300, 151 is right about 100, 300, 150, 100 using the countdown method. And then it's about 100 beats per minute. The regularity, as we can see right here, it's irregular because of that PAC right there. P waves are present and married when they're there, except in the PAC. Except at PAC. The PR interval is kind of tough to tell from here to here, so that looks to be about 0.20 second. The QRS, wow, that's nice and narrow. It has a lot of elevation, but that's in a separate class. That's a 12-lead class. So, but in this one, we look here, it's a very narrow QRS complex. So we're going to go ahead and say this is 0.08 second. Our interpretation, underlying rhythm always goes first. Now I keep saying that, and what that means is you cannot identify this rhythm as PAC because that is not the rhythm interpretation. That is the problem with the rhythm. That is not the rhythm. So you have to put what the rhythm is first and then start identifying all of the anomalies and all of the issues with the rhythm strip. So the rhythm strip right here, the interpretation is sinus tach with, it looks like there might be two PACs in here because you have a PAC right here, and then if you look all the way over here, there's another one right down there. So it looks like that there's two PACs in here. The problem that we have here is that we can see here that we have sinus, 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 and then PAC. So we have 1, 2, 3, 4, and then the fifth one. 1, 2, 3, 4, and then the fifth one is a PAC. This could be a normal pattern that occurs on this rhythm strip, but the problem is the rhythm strip for us isn't long enough. But we could say that this occurs every fifth, the PAC occurs every fifth beat. Now another question we have here is, would you say that these are compensatory or non-compensatory pauses? take your calipers and march it out. See if all of these P waves march out from the front side of the strip all the way to the back side of the strip. And in this case, they're not going to. All right, this rhythm, let me see what the atrial rate is. Starting here, 300, 150, 100, 75, 60. So we'll say 65-ish. And the ventricular rate is going to be 65 beats per minute because all the P waves have QRS complexes, irregularity. As you can see just by glancing, you have this problem right here. So this is going to be irregular. The P waves are going to be present and married. The PR intervals, let me see here, start here, end here, looks like 1, 2, 3, so 0.12 second. The QRS complexes look nice and narrow also, starting here, going to here, that's a 0.08 second. The underlying rhythm we have here, 65 beats per minute. Everything else looks fine except for this irregularity right here. I'd say it's a sinus rhythm with, we have one PAC right here, and then we also have another PAC back here. So we'd say, and this looks like we have a sinus, sinus, PAC, sinus, sinus, PAC. So we'll have a 1, 2, 3, 1, 2, 3. So it looks like we have trigeminal PACs. Now, are these pauses compensatory or non-compensatory? If you use your calipers and march out from the front side of the strip to the back side of the strip, you will see that these are non-compensatory. Because they do not march out. Last one here, then we can move on. Atrial rate looks to be here. Ooh, this is interesting. This actually looks like it's going to be harder to determine because we have bigeminal PACs here just by glancing at it. So I'm going to look here, and 300, 150, 100, so that's about a 90, 80 maybe. And then 300, 150, 100, 75, 60, 50, so there's a 50, so we'll just average it and say about 65, maybe 70. You can do the math and actually calculate it, but I'm kind of trying to hustle along here because I know how this can be drawn out. The regularity is going to be irregular. The P wave is present and married. The PR interval looks to be starting here, ending here. That's about a 0.16. The QRS complex, nice, steep, and steeply angled, sharply pointed, nice and narrow. So that's going to be a 0.08, looks like. The underlying rhythm is probably going to be a sinus rhythm. It's hard to tell here because we have bigeminal PACs, but we're just going to classify it and just umbrella term it and call it a sinus rhythm. So it's a sinus rhythm with, what do we have? Bigeminal PACs. Now we have to try to figure out the pause. Is it a compensatory or a non-compensatory pause? Unfortunately, you can't really tell if it's a compensatory or non-compensatory pause, and this is why. What is the normal P to P interval? And the answer is we don't know. And the reason is because here's a normal P wave. Whoop, I should use an S. Here's your sinus beat, which is a normal P wave, and then here's your PAC. For you to get a good P to P interval, you have to have at least 2 sinus beats in a row. And we don't have 2 sinus beats in a row. So if I know that this is my sinus beat, and I know this is a sinus beat, that's not my normal P to P interval. So you can split it and say, well, maybe it's right here, but maybe it wasn't. Maybe the normal sinus beat is supposed to be here again, or maybe it's supposed to be here again, and this PAC keeps resetting the SA node and keeps screwing everything up. So when you have a sinus rhythm with bigeminal PACs, PJCs, or PVCs, you don't know what the compensatory or non-compensatory pause answer is. You don't know if it's either one of those. So for this rhythm here, this right here, the sinus rhythm with bigeminal PACs is more than acceptable for your rhythm interpretation. This is the end of part 1 of the atrial rhythm interpretation video. It's a pretty long video, so I decided to go ahead and break each one of these up individually. So go ahead and please continue with all of the other videos after this one. Thank you.